Okie doke. So, okay, we got this will be helpful. We define substances and what a disorder is, what intoxication is, and what withdrawal is. Now, we're going to talk about, okay, how do we get a diagnosis for a substance use disorder? And, okay, how do you get a diagnosis for a substance use disorder? How do you get a diagnosis for intoxication? And then how do you get a diagnosis for withdrawal? All right, so I'm going to use alcohol as an example I will use alcohol as an example if I can get there. Okay. But in general, okay, so for every different drug, the criteria is going to switch just a little bit, but not much. But in general, this is generally what the diagnostic criteria is for every single substance. But again, every substance is going to affect everybody a little bit differently, so again, it's going to be tweaked just a hair, but in general, this is what it's going to look like. And in order to get a diagnosis, you have to have at least 2 of these criteria, 2 of 11 if I'm not mistaken. Yep, 2 of 11. And that's going to get you a mild substance use disorder. Whereas if you have 4 to 5 of these symptoms, you're going to get diagnosed with a moderate substance use disorder, and severe is going to be 6 or more. So that's where you can kind of see the differences. And if I'm being honest, most of us probably have a substance use disorder. If you enjoy caffeine immensely, we all probably have some sort of substance use disorder. I'll use my caffeine example. I enjoy caffeine immensely as an example for this. Anyways, okay, so the first one is, again, you only need 2 to get started. Taking the substance in larger amounts or for longer than you're meant to. Okay, taking the substance in larger amounts is going to indicate tolerance. Again, your body's kind of adapting to the effects of the drug. And so as a result of that, you need to take more and more. Okay, my example with caffeine. When I go off of caffeine for a hot minute, and then I start to use it again, I can just drink like a cup of coffee in the morning, and I am good. Like, I can go all day. It's awesome. That jacks me up enough, I can go all day. But you know what, like after a week, by 9 o'clock, I'm like, I need something else. The coffee's not doing it. So, we have more caffeine. And that's going to be good for, like, okay, like maybe that's good for a month. And then again, like then, by noon, I'm like, oh my God, I need something else. I'm going to fall asleep. And so I need that much more. I need something to do. And so that's indicating tolerance. You're going to need more and more of the substance in order to get the desired effect. Or if you're using it for longer than you want to, or it was meant to. Okay. Also, you want to cut down or stop using the substance, but you're not managing to. Okay? An example of this, okay, I'll give an example of somebody that maybe smokes or vapes. In that, there's a lot of people out there that try super hard, very, very hard to quit smoking or vaping. That is a huge commonality. Lots of people do that. Because again, we have the evidence to show us with smoking that it is going to increase your chances of a variety of diseases. We don't have that with vaping yet. Give us 10 years. But lots of people try to quit, or they want to quit, because they understand that, no, this is going to damage my body. And so they try to quit. But with nicotine, it's a really interesting thing. It's a really tough drug to quit. And so it's a lot of people that want to quit, they'll try to quit, and they don't quit. So yeah, you want to cut down, you want to stop, but you're having a hard time doing it. I'm even like that with caffeine. Like I just want to stop and like go all natural. I just want to do water. That is really hard. It would be great if I didn't need my cup of coffee in the morning. Am I going to stop drinking my cup of coffee in the morning? No. It's not going to happen. So there we go. Right off the bat, I've got 2 for caffeine use disorder. Boom. A mild caffeine use disorder, here we go. Also, spending a lot of time using or recovering from using the substance. Okay, that's probably not going to be caffeine, but maybe we're talking about alcohol. Maybe that's somebody's drug of choice. And so in regard to that, at some point, I mean, if somebody's drinking enough, maybe they're having hangovers. And so they are spending a lot of time recovering from the use of that drug. Or if we're talking about something a little more illicit, like cocaine, heroin, they might spend a lot of time trying to find that drug. That's a little bit tougher because it is illegal. Okay, so that might be one. Number 4, cravings and urges to use the substance. I'll be honest, when I wake up in the morning, I crave my coffee. I absolutely crave my cup of coffee. Again, I know the caffeine example is very PG rated, but I do crave my coffee. I do have these urges to use caffeine. Whereas other people, maybe it is, maybe it is heroin. Maybe it is methamphetamine. Those cravings and urges are going to be extreme, especially if somebody is physically dependent upon the drug. Also, not managing to do what you should do at work, home, or school because of substance use. So again, maybe you have a hangover and you can't perform as well at school or at work, and maybe you're not going to classes. Or, maybe you're spending too much time at the bar, and so it's affecting your relationship. And you continue to use, even when it causes problems in relationships. There you go. So instead of hanging out with your friends, hanging out with your family, you are out looking for your drug. Maybe you're at the bar, but you kind of trade relationships for your drug. And you keep using. All right, here's another page. Giving up important social, occupational, or recreational activities because of substance use. Yes, so instead of doing all of the normal activities that you used to do, now you're spending more time using. Okay, using the substances repeatedly, even when it puts you in danger. So even if, maybe we can talk about heroin here. And so even if trying to buy heroin, you're trying to buy heroin from somebody, let's say in town. And you understand that, that's going to be a little bit sketchy. You don't know how this is going to go down. You don't know if you are in danger, because drug deals go bad. But you still put yourself in that position. Or you also understand, maybe I'll get arrested while this is happening, or when I have possession of it. That is a danger as well, but you still do it. In regard to just something like nicotine, again, when you use it for an extended period of time, it increases your chances of a variety of diseases and issues, but you still do it. You're putting yourself in danger, but you still do it. Also, needing more of the substance to get the effect you want, there's tolerance again. And the development of withdrawal symptoms, which can be relieved by taking more of the substance. Yes, every time that I go off of caffeine, I have withdrawal symptoms. And the withdrawal symptoms are going to be the opposite of the intoxication symptoms. And so, my central nervous system gets jacked up, and so I'm irritable. I've never really had shakes, but I've known people that get shakes. I get headaches. So that's going to be some of the results of that. But again, if I just use my caffeine, I am going to get rid of my withdrawals. And that's commonly what people do. Once they start to experience withdrawals, they can be painful enough that they'll be like, okay, screw it, I'm just going to use again. So again, in order to get a mild substance use disorder diagnosis, you're going to need 2 to 3, 4 to 5 for moderate, and 6 or more for severe. So, and some of these you're going to see more often than others. I've never seen a caffeine use disorder in a psychological or substance use evaluation. Never seen it. I'm sure that it's useful in some contexts. I've never even seen a tobacco use disorder, but it was nice that a student, she has seen it before, because it can be useful for insurance purposes. And so one thing that can be done is if somebody's diagnosed with a tobacco use disorder, is you can bill insurance and you can get the medication that helps people quit smoking. It'll cover it then. So that can be part of it as well, in that it's going to help a person if they want to get off of that drug, regardless of what it is. Insurance can cover it and potentially cover any medications or therapies that can help them. So in regard to some of these substances, again, they might sound kind of silly, but there are purposes. Okay. All right, so again, that's all it's going to take to get a substance use disorder diagnosis. Let me see if there's anything else I need to say about that. Oh, I'll just talk about this for a hot minute, okay? So when it comes to alcohol, specifically, again, alcohol is a very, I'll roll back up. Alcohol is a very prominent substance used in our culture. You go out with friends, again, unless you're 21, of course, you've never used alcohol, but you go out with friends, once you're 21, there could be alcohol involved. You go to a wedding, most weddings have alcohol. So you go to all these social functions, and there's commonly alcohol. And there's a certain expectation as well that, like, oh, you're going to have a drink as well. There's even an expectation, like, for you guys that are in college, that, like, okay, you're going to go out and you're going to party, you're going to drink. I mean, at some colleges, like, binge drinking is it's almost encouraged. And so, with that being said, again, alcohol use is extraordinarily normalized in society, even though it's the one drug from which you can die as a result of withdrawal effects. But we still do it. And so when it comes to alcohol use disorders, they're very prevalent. So when it comes to this, our lifetime risk of developing an alcohol use disorder is going to be right around 30%. So basically what that says is one of us in this room, at least one of us in this room will be diagnosed with an alcohol use disorder at some point in our lives. 30%, that's so high. That's so incredibly high. And then on top of it, not only is it 30%, but in regard to the severities of that 30%, 8% is going to be mild, 6% is going to be moderate, and 14% is going to be severe. Which indicates that, again, of the alcohol use disorders that are going to be diagnosed, about half of them are going to be severe alcohol use disorder, which shows, like, we have an issue. We have an issue. Yeah, and honestly, your age group is most at risk. Let's see here. The 12-month prevalence of alcohol use disorders in the United States, okay. 4% of individuals 12 to 17 years of age. 16% of 18 to 29-year-olds. So, like, your age group is going to be the most at risk for developing an alcohol use disorder. And then 1.5% among people 65 and older. We kind of mellow out as we get older. So, again, very high risk for developing that. And again, it's because it's so acceptable in our society. And it's so accessible as well. Okay, so with that being said, now that I've gotten on my soapbox, so obviously I'm like, please don't drink. If you do, don't, I don't know what to say. Please don't. It's a more dangerous drug than you think it is. And I am saying that out of experience. Okay, so then, you get a substance use disorder maybe, and some people might get a diagnosis for substance intoxication. Okay, and this is going to be helpful if somebody shows up to their therapy appointment and maybe they're drunk or maybe they're high. You could be diagnosed with substance intoxication if you are currently intoxicated in the presence of a clinician. And so this is helpful. It's helpful for documentation. It's also helpful for possibly getting somebody into treatment. If somebody is showing up drunk or high to a therapy session, we might have an issue. Anyways, okay, the intoxication is what you think it is. It's like when somebody is actively using a drug. So it's the development of a reversible substance-specific syndrome due to the recent ingestion of a substance. Yes, somebody has recently used and they're experiencing the effects of the substance. So with alcohol, maybe they're stumbling, maybe they can't put a sentence together. There's a couple others here that are, it's not funny, but I'm like, well, this shows the concern about this. Slurred speech, lack of coordination, unsteady gait, you can't walk in a straight line. Nystagmus, your therapist probably isn't going to check you for that. Your attention and memory isn't there. The last one here, coma. That is an indication of being intoxicated with alcohol. Yes. If you're a clinician and your client shows up and you can smell alcohol on them and they drop into a coma, we probably have an issue. Okie dokie. I have to mention that one because I'm like, oh my, what? Yeah. Okay. Anyways. Okay, so that is that one, and then it is, okay, the clinically significant behavior or psychological changes along with the physiological effects of the substance developed during or shortly after the use of substances. Yes, so you have to make sure like they have recently used. Again, with alcohol, they could have used in the parking lot. Maybe they're high on weed. They could have used like within the last 4 hours, 6 hours. So just depending upon what drug it is, they have to have recently used it in the amount of time that you would commonly expect intoxication to occur. It just depends on the substance. And yeah, accompanied by substance-specific signs and symptoms, as we indicated. And all you need for the intoxication diagnosis, you need one of those that I mentioned. Yeah, you're in a coma, boom. Or, again, you smell like alcohol and you're slurring your speech. There we go. You only need one. You only need one of those. And it's not attributable to another medical condition and is not better explained by another mental disorder. So, I'm trying to think of something to rule out. Maybe somebody, oh God. Honestly, because I know this can happen, maybe somebody has, they're abusing like Vicodin. And they've taken way too much Vicodin. Actually, one of the symptoms of taking way too much Vicodin is hallucinations. And so it wouldn't be out of the possibility that somebody is hallucinating, so you would have to make sure that it is due to the result of the Vicodin and not possibly hallucinations related to psychosis or schizophrenia. So in that case, you would just have to do a differential diagnosis, like to make sure, like, okay, this isn't psychosis, this is Vicodin. That would be an example of that. Okay, we have intoxication. Okay, yeah, drunk, statistics, that's gonna break it on that. Okay, so you can be diagnosed with substance intoxication, then you can be diagnosed with substance withdrawal. And again, this is when somebody is going to lessen or stop using a specific substance, and you're going to develop substance-specific problematic behavioral change. You're going to have physiological and psychological symptoms due to the, stopping or reducing the amount of the substance that you use. Okay, so that's going to be there. Then you have substance-specific withdrawal effects. Okay, and this is going to be different from, this will vary immensely from substance to substance. So you have like alcohol withdrawal and opioid withdrawal and cocaine withdrawal. With alcohol withdrawal, you need just 2 of the following diagnostic criteria. So you need, okay, and again, it's going to be the opposite of the effects of alcohol. Alcohol is a depressant, and so you're going to have stimulating effects. So instead of your system slowing down, it's going to jack it up. So you might have autonomic hyperactivity, so sweating, and your heart rate is like at least 100 beats per minute. Should not be that. Your heart feels like it's going to beat out of its chest. Hand tremors, you get shakes, that's a common one. And some, you can't sleep, insomnia. Again, that central nervous system is just jacked. Nausea or vomiting. With a lot of these substances, nausea and vomiting is probably going to come along with it. Visual, tactile, or hallucinations. Psychomotor agitation, like you just can't sit still. You can't sit still, you're restless. Anxiety, and then also you have seizures. And this is what can kill you. This is the thing that can kill you. I know I keep I hit on this way too much in all my classes, but I never think I can hit on it enough because, again, this is what kills people. It's these seizures. If somebody's withdrawing from alcohol and it's extraordinarily severe, if they have one of these seizures, it can kill them. So that's, again, why I recommend, if your buddy is withdrawing from alcohol, take them to the hospital. They need to be hospitalized. Because what they'll give them at the hospital, they will commonly give people a benzo like Ativan, and that is going to lessen the severity of the seizures or stop them altogether, and they will live. Alcohol withdrawal is not something like if your buddy's withdrawing, do not leave them in the house. No, they need to go, they absolutely need to go to the hospital. And that's in comparison to, like, again, withdrawing from most other drugs. Again, if they have, like, if they've got other issues, maybe they have some physical issues, maybe other psychological issues, maybe then you want to try to get them maybe to some sort of rehab or detox. But in general, again, there are no other drugs from which you will die. You will die from the direct effects of the withdrawal. There might be other issues that kill somebody, but the direct effects of the withdrawal, alcohol is the only one. Are other withdrawals going to be uncomfortable? Absolutely. Somebody's withdrawing from heroin, that's going to be god-awful. But it's not going to kill them, unless there's other things going on, like I said. So, you need 2 of those withdrawal effects, and then they're causing clinical distress. There's some sort of distress and dysfunction. Like we need that with every single diagnosis. There's some sort of distress or dysfunction, and if you're withdrawing from a drug, you're going to feel a little bit of distress. You're going to feel a little bit of distress. It's possibly going to get in the way of your life. Maybe you're not going to class, you're not going to work, you might not be getting out of bed. And so there's your distress and dysfunction. And the symptoms are not attributable to another medical condition and are not better explained by another mental disorder. So again, you have to prove that it is the effect of somebody quitting alcohol. Let me see if there's anything in here I want to tell you about alcohol. Yeah, in regard to withdrawing from alcohol, the withdrawal effects are going to become more serious as somebody gets older. So usually with alcohol withdrawal, it's going to last about 4 to 5 days. And that's only the physical withdrawal effects. The psychological ones really don't ever leave you necessarily. Those are going to stick. They might lessen over time depending upon your coping skills. Maybe you go to AA, things like that. That helps. But that psychological craving, I don't know if it necessarily ever goes away. Yes, withdrawal is relatively rare in individuals younger than 30, but it's going to increase with age. So if somebody's withdrawing from alcohol before the age of 30, you're not going to experience tons of withdrawal effects, but as you get older, that's going to increase your risk of the severe ones. Let me see here. Okay, with that, do you guys have questions about those diagnoses? So in regard to caffeine, just if you want a fun fact, 85% of adults and children in the U.S. Regularly consume caffeine. We have a caffeine issue. It could be worse. Marijuana. I thought I got something for marijuana. It's not that high. Oh, that's among cannabis users. Never mind. Okay, I'll keep going here. All right, so here's the thing with substance use disorders or addictions. They are going to co-occur with physical and mental health conditions in adults and adolescents with extreme regularity. That's one thing that I saw a lot when I was working at Region 2, are a lot of dual diagnoses. So you have people with substance use disorders, but then you also have a co-occurring mental health disorder, and depending upon what the mental health disorder is, depending on what that disorder is, and how severe it is, that kind of increased chances of substance use disorders. And depending upon how long somebody has gotten treatment, or how long their mental health disorder has gone on and they haven't gotten treatment, like a lot of people will self-medicate. That's what I'm trying to get to. A lot of people will self-medicate their mental health issues. So if we talk about somebody who has like depression or anxiety, alcohol is a common coping mechanism. It's accessible, it's easy, you don't have to do a lot of work. And you can deny that you have any mental health issues, which we commonly do in our society. But again, that is going to set you up for, again, a mental health diagnosis at some point and potentially a substance use disorder if you become like dependent on it to cope with your mental health issues. Yes, of course, it's going to cause significant distress and complicate psychological treatments. Usually, when there is a co-occurring mental health and substance use disorder, you're going to try to tackle the substance use one first. You can do it together, but you really try to hit on the substance use one first. I don't know why this slide is on here. But no, it is important to understand that there are, even in regard, okay, and we haven't talked about it yet, but that is one thing that is extraordinarily common, like in anorexia nervosa, is substance use. And in regard to that, anorexia nervosa has an extremely high mortality rate, but it's not always the result of the anorexia. It can be the result of also suicide and overdoses. So we see that pretty commonly. Okay, another thing that we have here outside of the substances is gambling disorders. And so with a gambling disorder, I think this was added in 2013, and what this is leading to is, because you are not going to become physically dependent on gambling, you will become psychologically addicted to it though. Like if you stop gambling, you're not going to be nauseous and throwing up. You will be irritable, you're going to experience those withdrawal effects, but it's going to be psychological, not physical. And so what's good about adding this gambling disorder is that we're paving the way to add new things like electronic use type of disorder, maybe video games. We might start to be able to add those things. Because even though it's not physically necessarily addictive, it's psychologically addictive. So, with the gambling use disorder, it's fairly similar to your other substance use disorders. You have reoccurring problematic gambling behavior that's going to result in impairment or distress. And you have 4 of the symptoms within a 12-month period, so you need to gamble with increasing amounts to achieve the desired excitement, so you're not getting the same dopamine hit. You're restless or irritable when you try to cut down or stop gambling. You made repeated unsuccessful efforts to control or cut back or stop gambling, like you just can't kick it. You might be preoccupied with gambling. You have persistent thoughts of reliving past gambling experiences, planning the next gambling experiences, who you're going to bet on tonight, things like that. You often gamble when you feel distressed. It's a coping mechanism. It's going to make me feel better for a while. After you lose money, you return to basically get even. Like, okay, I lost $200 last night. All right, I'm going to make that back tonight. I'm going to make sure I put enough money down that I'm going to make it back tonight. You lie to conceal the extent of involvement in gambling. So yeah, you lie to family and friends. You potentially lost a significant relationship, job, or educational or career opportunity because of gambling. And possibly because you relied on others to provide money to relieve desperate financial situations caused by gambling. So maybe you took out a second mortgage and then you ended up getting a divorce. Or you're asking friends for money and you lose it gambling. So those 2 things can come together. But you need 4 of those and you could be diagnosed with a gambling disorder. We don't have prevalence rates. Wait, no, we do. The prevalence rate of gambling disorder is right around 0.2 to 0.3% of people. It's low. It's pretty low. Now, as gambling becomes more, like sports gambling, becomes more legal across the United States, which is happening, you might see these numbers bump a little bit. Or gambling becomes legal in certain states. Again, gambling was not legal in Nebraska until only recently. Now we're seeing casinos pop up all across Nebraska. So the accessibility might change some of these numbers. Let me see what else I got here. Oh God, we've talked about this. Let me think here. let's talk about something else. Okay, we talked about that. Talked about that. Okay, I've got to talk about that. Okay, hold up. Okay, so going back to the co-occurring disorders for a minute, because again, this is, if you work with individuals who have psychological disorders, again, those substance use disorders is something you gotta look out for, or help them get treatment for. And some of the common co-occurring mental health or psychological disorders with substance use disorders, these are those. So like depression and anxiety, that's going to have a high comorbidity rate with substance use disorders. Any sort of externalizing disorders, personality disorders. We see that very commonly among, especially if we're talking about cluster B personality disorders, if we're talking about like antisocial personality disorders, borderline personality disorder, histrionic personality disorder, we're going to see that. PTSD, yes, again, it's coping mechanisms. Again, not healthy coping mechanisms, but coping mechanisms. But here's the tough thing, is what came first? Was it the psychological disorder or substance use disorder? Okay, was it the chicken or the egg? And it is difficult to determine the direction and causal relationship. We just know there's a correlation. We just know that if you have a certain psychological disorder, that's going to increase the chances that you also have a substance use disorder, and vice versa as well. But we can't say like, okay, this psychological disorder caused the alcohol abuse. We just can't say that. There's always going to be a correlation, not a causal relationship. Walgreens, I do not need your help. Yeah, it is going to require in-depth assessment of the onset of each condition, and often the co-occurrence happens simultaneously, showing up in similar time frame. So again, it could be one or the other. Okay, so just in regard to, any psychological disorder, with any psychological disorder diagnosis, there is an 18.7% chance of an individual also having a substance use disorder. Again, very commonly co-occurring. Serious mental illnesses, so this would be like schizophrenia, bipolar disorder, maybe there's so many people in suits here today, I do not know what's happening. A serious mental illness, schizophrenia, bipolar disorder, polypersonality personality disorder, about 4%. Any mental illness and substance use disorder together, 6%, and then serious one, 1.6%. So, why co-occurrent? So common risk factors can contribute to both of them. Could be genetics, could be in the environment. So maybe you do have the genetics for the genetic inheritance for something like depression. But maybe you also have addiction that runs in your family. There's the genetic predisposition. But then you are going to need some environmental stressors. Traumas, stressors, that's what's going to aid in the expression of all of that genetic material. Also, yes, mental health issues contribute to drug use and substance use disorders, self-medication, coping. Also, brain changes due to mental illness may enhance rewarding effects or reduce perception of negative effects of substances. Yeah, it could kind of, the word is not coming, but basically that increased dopamine is going to be sought after, or again, you kind of lose the ability to recognize like this is going to end very badly. So it changes your perception of the reality of substance use. Substance use and addiction can contribute to the development of psychological disorders. For example, like substance-induced psychotic disorder. We have that specifically because if people utilize certain substances at certain rates for a chronic amount of time, it's not out of the realm of possibility that they can actually cause changes in their brain to be diagnosed with like a psychotic disorder. So we do see substance-induced psychosis. So that can explain some of the co-occurrence between drugs and alcohol. And I totally explained, it's going to bug me, I totally explained this chart wrong. Sorry, I can't read charts. Okay. In society, there's an 18% chance you're going to develop a psychological disorder, or 4% for a serious mental illness. 6% of people with a psychological disorder, there's 6% of people in society that have a psychological disorder and a substance use disorder. There we go. It was going to bug me so much if I didn't go back and correct myself. Sorry. I've been thinking of it on that whole slide. I'm like, I can't keep going. Okay. Common co-occurrences, again, other substance use disorders like smoking, depression, anxiety, PTSD. Yeah, suicidality. It's not out of the realm of possibility that suicidality is going to increase in somebody, for example, that has major depressive disorder and is drinking heavily. That would be an example of that. Okay, let me see here what else I've got. Okay, this one, I think this one's kind of interesting, or you guys might find this interesting. Okay, so comorbid substance use disorders. Okay, so this is going to give you a little more insight into, like, okay, in regard to, oh, these go together. Okay, I thought we were going to get something else. Okay, in regard to the co-occurrence of different substance use disorders, so what substances do people use together? All right, so for example, with alcohol use disorder, almost 24% of people who are diagnosed with an alcohol use disorder are also going to be diagnosed with a tobacco use disorder. Smoking and drinking go together. About 10% of people diagnosed with alcohol use disorder will be diagnosed with a marijuana use disorder, 3% with a cocaine use, opioids 4%, and right under 1% for heroin. Let me go down to the other ones. Among people who have a marijuana use disorder, 40% of people will also have an alcohol use disorder. 30% will have a nicotine dependence. Wow. Cocaine use disorder? Good God. Sorry, I haven't read these in a long time because we never get this far in this PowerPoint. So with cocaine use disorder, somebody's diagnosed with that. They also have a 60% chance of developing a co-occurring alcohol use disorder. 50% chance of a nicotine use disorder. And then with opioids, yeah, 35% chance of having alcohol use and prescription opioid use disorder. 45% chance to also have a tobacco use disorder. Whether that's vaping or smoking, it could be either. Even though tobacco is not the psychoactive ingredient present, it's nicotine, but the APA does not have them sitting at the table. Anyways, heroin use disorder, about 25% will also have an alcohol use disorder. 2 out of 3 will also have a nicotine use disorder or a tobacco use disorder. So that's pretty high. So that gives you a little indication of like what drugs kind of go together commonly. We've already talked about this. I might just roll to... Oh, no, I'm not. I'm going to talk about this. Okay, how do we treat this? How do we treat substance use disorders, especially if they're moderate or severe? To possibly mild. If we're talking about somebody who might be using heroin and they have a mild heroin use disorder, well, we probably want to, we might be looking at treatment. Any sort of heroin use, we might be looking at treatment here. Okay. There are some important medications that are now being used to manage withdrawal and the neurobiological aspects of these disorders. So, in regard to opiates, yes, in regard to opiates, I gotta get the... Yep, that's what it is. Okay, methadone. Methadone is like the tried and true traditional drug that if somebody's trying to get off of opiates or like heroin, they'll give you something like methadone. I don't know how many methadone clinics we still have in the United States, but there used to be methadone clinics. You show up, get your methadone for the day, go home. And what methadone is, it's a lower level opiate-like substance. So it's like you're easing yourself off of the opioids or the heroin. And you're not doing it completely cold turkey. So it kind of lessens those withdrawal symptoms and the cravings. We also have, okay, this is Suboxone. I'm sorry. It's a buprenorphine. We have Suboxone. I think that a lot of people are on Suboxone. But again, it's basically another It's kind of like methadone, and it's going to ease somebody off of those opioids. And then we also have Vivitrol. I don't know how accessible Vivitrol is, but this is an injectable drug that people can use in order to work their way off of opioids. So again, it's going to ease the withdrawal effects, it's going to lessen the cravings and urges for somebody to use again. That's the important part of this. And with some of these, and I think it's Vivitrol, that it's like once a month. You can get it once a month. Methadone, you might be needed to get it daily. Suboxone, you can get it in pills, so you can do it at home. Vivitrol, I think it's a monthly injection. Also, if we're talking about alcohol, okay, so these are good for depressants. These are good for depressants, specifically opiates. But you also see naltrexone down here, because again, alcohol is also going to be a depressant, so it helps withdraw off of these depressant type substances. Antabuse is a very traditional drug that's used in order to help people stop using alcohol. And what happens when people take their Antabuse is that they will go to possibly drink, and it makes them physically ill. Some people it just makes nauseous, other people get like violently sick. So that's what the Antabuse is. When that alcohol and Antabuse collide, creates immense amounts of nausea and illness. Naltrexone, that's going to be similar to the Vivitrol, but it's not injectable. Acamprosate, I'm not sure what acamprosate is. But we can find it. Acamprosate. It also reduces the desire to drink alcohol. It doesn't prevent the withdrawal effects, but helps the brains of people who have drank large amounts of alcohol to work normally again. I'm guessing it might decrease the urge to use more than anything. I think it works on the addiction side and not on the withdrawal side as much. Okay, nicotine. Okay, somebody wants to quit smoking. Chantix, that's a big one. Even some employers, like wellness programs, you can get like Chantix through. It's cool. Wellbutrin actually also helps people stop smoking, vaping. Wellbutrin is commonly used as an antidepressant. It's very commonly used as an antidepressant, but it's also a smoking cessation aid. Kind of cool. Okay, NRT. Not sure what NRT is, but I've seen primarily Chantix used. But I also know people who use Wellbutrin for depression, and they quit smoking. That wasn't the purpose, but they ended up quitting smoking, which is awesome. It's important to be aware of these medications in comorbid clients because they do have interactions and implications for treatment. And so maybe you do have depression and you're on an antidepressant that works, maybe you're on an SSRI, and for whatever reason the SSRI does not jive well with Wellbutrin and they want to stop smoking, don't put them on Wellbutrin. So you gotta make sure these drug interactions don't butt heads. Yeah, nicotine increases metabolism of many psychotropic medications, and so you might, instead of having somebody on like a normal SSRI, you might need to put them on an extended release because it's being metabolized too quickly, so they're not experiencing the effects for the full amount of time, so they might need an extended release, or maybe they need to take an additional dose. Methadone at high doses can produce drowsiness and difficulty focusing. Yes, it absolutely can because it's an opiate-like substance. Chantix can produce vivid dreams and depression. So that's going to be a side effects of those. But combining medication and psychosocial treatment is often an important part of recovery and standard of care. Yeah, and very commonly, you're just not going to be allowed to. Nicotine's different. But if we're talking about alcohol, if we're talking about opiates, you're going to be in some sort of like talk therapy as well, or a group, or intensive outpatient program, or maybe you're at an inpatient treatment facility. All of those are possible. We know that. Got enough time. No. Yeah, the internet gaming disorder, internet or gaming disorder is something, again, it's not in the DSM yet, but I put money on it in the next 10 years it will be. In regard to this, I think that like clinicians can still consider it, you just can't be diagnosed with it, like formally. But this is when you play like multiplayer games, okay, like World of Warcraft. I think we were talking about World of Warcraft yesterday. Yeah, let's use World of Warcraft. I don't know my multiple, and you were talking about some too, weren't you? Which example did you get?
Siege.
Siege!
Fortnite and like Call of Duty or some other big ones.
I have seen multiple people this semester fall into Fortnite addictions. They will play it in my class. They do, yes. I've never played it. I don't know. Call of Duty, that's, yeah. I've never played World of Warcraft. Never played World of Warcraft, Siege 4. I probably need to stay away. You'll never see me again. I don't know, maybe. So like, okay, World of Warcraft, Siege, Fortnite, oh god. Okay, so the criteria for an internet gaming disorder, you have persistent engagement and preoccupation with gaming. Yes, that's all you do. Tolerance. So you need to play more and more and more and more to the extent maybe you're playing all night, staying up till 4 a.m., or you're playing in class. Withdrawal. You're getting really irritated when you can't play. You're going to get really irritated. You need to go find Fortnite now. Loss of interest in other activities. Yeah, you're not like going outside and or like going for a walk. Maybe you're not going to like practices or going to the gym or reading books like you used to because, oh my god, we got to play World of Warcraft. And there is clinically significant impairment or distress. It's getting in the way of your life. I don't know how much distress there's going to be because people enjoy it, but maybe they'll start to feel distressed when, again, they're maybe not showing up to work, they don't show up to class anymore, they're starting to fail classes because they just play these games in class. So then distress might start to come into play. So if you see that in others, talk to them, please. Just say. Support them. Okay. We have time. So, okay, this is what we're going to do for the remaining amount of time. I'm going to talk to you about personality disorders. We talked a little bit about this in the personality chapter because we talked about psychopathy. I'm pretty sure that was even an exam question, and that I was like, okay, you can't be diagnosed with psychopathy anymore, but you can be diagnosed with antisocial personality disorder. Okay, so, all right, so with personality disorders are very different than the rest of the disorders because what happens with the rest of the disorders is that there's like these extraneous symptoms or you're losing some of yourself. Like again, the abolition, the anhedonia, you're losing part of who you are. It's like taken away, or you're adding symptoms like depression or anxiety or like hallucinations that shouldn't be there. Okay, so you have these extraneous symptoms, but when we talk about personality disorders, this is who they are. Like somebody that has depression, yes, they have depression, but you know who the person is. The person is somebody that you know that they have depression on top of who they are. Or anxiety on top of who they are. But when it comes to a personality disorder, it's literally who they are. This is their personality. And in order to be diagnosed with personality disorder, it's a type of personality that's like outside of what is quote-unquote normal in our society. And it's causing dysfunction in their lives or others' lives, and it can cause distress to them to a certain degree, but again, that's what's going to be hard about personality disorders, is the person that has it takes a lot of self-awareness to deal with a personality disorder, because this is who they are. So what, like if a clinician would say to me if I had a personality disorder, like we need to address this. But there's nothing wrong, this is literally who I am. So you want to change who I am? We're not treating extraneous symptoms. You're telling me that you're going to treat who I am. You want to change my personality, which is also very difficult because it would be like changing your guys' personality. Like, how do we do that? So commonly, when we treat personality disorders, we're looking at like, okay, are there extra symptoms here that maybe we can address? Because maybe there is some like depression that's going to start to arise. Or maybe there's some other issues. Maybe there's a substance issue we can start to address. Maybe we can teach them some skills so they can function better in society. And we have, I'm only going to talk, we're going to just jump to cluster B personality disorders. Those are the ones that you're going to come into contact with most. A, these are autocentric personality disorders. It's going to be like schizoid personality disorders. These individuals don't feel the need, they don't need to have like relationships with other people. They don't feel the need. Like we're social creatures, they aren't. But in general, they're commonly they can be successful in society. When I think of somebody with this, and again, I know I'm stereotyping, but if you've ever watched Mr. Robot, I'm pretty sure he has schizoid personality disorder, and he's like a computer programmer. He doesn't interact with others very well, but he's really good at like computer programming. He does very well on his own. So they can still be successful. Schizotypal personality disorder is kind of like an offshoot of schizophrenia. But again, it's who they are. It's not additional symptoms, but it's who they are. The other one I'm blanking on. Schizoid. Histrionic. No, missing one here. Missing one. Paranoid personality disorder. Yes. And again, this isn't like the additional effects of like schizophrenia where people are worried, like delusional. It's not additional to who they are. This is who they are in general. Just high levels of paranoia in every aspect of their life. Okay, but B. B is going to be the dramatic emotional personality disorder. So this will include like histrionic personality. I went too hard. Histrionic personality disorder. Histrionic personality disorder, borderline personality disorder, narcissistic personality disorder, and antisocial personality disorder. Those are going to be the most common ones you run into. And commonly the reason is because there's certain amounts of impulsivity and even antisocial behavior that can occur with people that have these disorders that might get them ending up in like a clinician's office or the criminal justice system or something like that. So that's how they will end up in an office. But nonetheless, this personality disorder, yes, it's an inner experience and behavior. It's your personality that deviates markedly from the cultural expectations. It's inflexible. Again, this is who they are. It's like saying, again, we're going to change who you are. And onset in adolescence, about that time, like personality becomes fairly stable over time, and it leads to distress or impairment. It's an extreme set of characteristics that goes beyond the range found in most people. So it's like extreme versions of quote-unquote normal personality. Let's see here. Okay. Jumping. Sorry, guys. I learned how to do GIFs. The eyes go back and forth. I was so proud of myself. Okay. That was my timeout. Sorry. People better watch out. I can do GIFs now. Okay. All right. So again, sorry, I'm fascinated by these disorders. Okay, dramatic emotional ones. Here we go. Antisocial, borderline, histrionic, narcissistic. Just to give you an idea of the key features, because we're not going to get to them all. Antisocial. This would be the traditional psychopathy or sociopathy, whatever you want to say. Like your Ted Bundy types. But at the same time, we got people that have antisocial personality disorder that are running around all over the place or super successful and powerful. Because of the characteristics of their personality, they're willing to do things that other people are not. So, pattern of disregard for and violation of the rights of others. Again, they don't care if they step on your head. Again, if we have an extreme level of antisocial personality disorder, literally or figuratively, they can slit your throat and not think twice. Okie dokie. They can be criminal, we see that, impulsive, manipulative, callous. And they don't In some instances, they can feel guilt. In other instances, they don't. Depending upon the severity, some will not feel guilt at all. Others, they might in certain situations. So again, it depends on the severity. Borderline personality disorder, instability in self-image, and in some cases, individuals with borderline personality disorder primarily develops as a result of trauma, early childhood trauma. They are missing aspects of like their emotional development that should have developed early on in life. It did not happen. But very commonly the result of early childhood trauma, instability in self-image. In some cases, they don't have a sense of self. They don't know who they are. Mood and interpersonal relationships, very unstable. Unstable moods. And so like when we talked about bipolar disorder, we talked about like, okay, going up the roller coaster and back down. It's slower with bipolar disorder. With borderline personality disorder, this can be like minute to minute. Okay, minute to minute. Somebody could be like happy and laughing 1 minute and then the next, they're rageful. That's borderline personality disorder. That is not bipolar disorder. Yes, impulsivity, dissociative states. The dissociative states are commonly the result of the early childhood trauma, and that's how their brain copes with stress. They're reactive to real or imagined abandonment. That's also part of that. And very commonly, like there's something that happened early on in their childhood that they possibly perceived or experienced some sort of abandonment. And so as a result of that, they're terrified of being abandoned. In a case of a relationship with somebody that might have borderline personality disorder, again, they might be like overly like codependent or needy in some cases, and so they're terrified of you leaving them, or in some cases they'll be like, this isn't going well, I can't be abandoned, so I'm gonna leave you before you leave me. Histrionic personality disorder. These people want the spotlight. It is me all the time. The attention needs to be on me. This is a pattern of excessive emotionality and attention seeking. Dramatic, seductive, or provocative behavior, again, to get attention. We want all the attention. They're suggestible and they have shallow emotional expression and relationships. So they don't really develop deep relationships, whether that's intimately, friendship-wise, anything else. It's all very shallow and superficial. But again, all the attention needs to be on me. That's histrionic. And again, it's not just like somebody that's seeking attention here and there. It is them all the time. All the time. There's no deviation. This is who they are all the time. Then we have narcissistic personality disorder, a pattern of grandiosity, for admiration, and lack of empathy, entitled, arrogant, and exploitative attitudes and behavior. Again, I am the best. Not only am I the best at everything, I'm the smartest, I'm the most beautiful, I'm going to be the most powerful, and I deserve everything. They're incredibly entitled. I don't necessarily need to work for anything, but I'm the best, so I deserve everything. I don't do anything wrong, you are wrong, I'm never wrong. Because again, I'm the smartest person in the room, all the time. They're arrogant. Again, arrogant, they're narcissistic. Okay, we can all be arrogant here and there, they're narcissistic. Yeah, they're exploitative as well. In order to get what I want, I will screw you over. And they need admiration. This is one thing about narcissists that's super interesting, because there's also this thing called narcissistic collapse. In that if somebody who is narcissistic, they're not getting that admiration that they believe they're entitled to, things are turning against them. Maybe like society is like reacting to them finally for the things that they've done. Maybe they're in trouble. Maybe they're losing people around them. And they start to see this happening. What you see is a narcissistic collapse. You will see them act out. You will see them start to be impulsive, because they're trying to hang on to those things that hold up their self-image, hold up this grandiosity, and they're losing that. So they're going to like lash out in whatever way they have. That's a signal of a narcissistic collapse. Okay, here's another thing, and you can't be diagnosed with it, but you can be diagnosed with both, and so it kind of makes you this. If somebody's diagnosed, let's say somebody has antisocial behavior or personality disorder and narcissistic personality disorder. Now, none of these in and of themselves, they don't bother me that much. Like, I've worked with people with most of these. You mix narcissistic personality disorder and antisocial personality disorder together, and what you get is what we call malignant narcissism. So now we have somebody, because sometimes for people with antisocial personality disorder, they kind of recognize they recognize that they are human to a certain degree, and they don't become, the narcissistic aspect, okay, I'm going to say this. The addition of narcissism makes them that much more dangerous. It increases their dangers because, again, I am the best, I need admiration, and I will do whatever it takes to get that because I don't care if I slit somebody's throat. As long as I get that admiration. So the mixture of these two, that honestly scares me. Most of these disorders, I don't know if there's any other disorder that really, in this whole DSM, that scares me. This one does. These are people that can burn the world down. That's what scares me. So if you want more, there's plenty on malignant narcissism online. I'm going to jump. Let's talk about borderline for a minute. You probably are going to run into this more than you think. And what borderline personality disorder is, it's their personality. This is who they are, this is how they act all the time. Instability of interpersonal relationships. Again, they're up, down, all around, not necessarily able to maintain them. Again, an unsteady self-image. Sometimes they don't even have an identity. Impulsivity. Again, early adulthood through the rest of their life. And you need 5 more of the following to be diagnosed. So, again, they're going to try to avoid real or imagined abandonment. Even if somebody in their life, again, is not going to abandon them, not going to leave them, they can perceive that they are going to be abandoned. They're always convinced, like, some people will always leave. They will always leave. And so as a result of that, I need to do whatever it takes to make sure they don't leave. And again, that can become pretty extreme in regard to behaviors. Unstable and intense interpersonal relationships, altering between extremes of idealization and devaluation. This is called splitting. This is something that happens in borderline personality disorder. It's what's called, again, splitting. And so what happens is that in any relationship, again, people are going to hurt you. Your friends are going to hurt you. You can love them, like them, they're going to hurt you, and you're going to make amends, and things will be fine. Because again, everybody makes mistakes. And you can understand that, like, everybody's human, and so there's like gray for most people. For people with borderline personality disorder, it's black and white. That's what's called splitting. It's when nothing is gray, it splits, it's black and white. Either you are evil, or you're the love of my life. And it goes back and forth. Also intense, again, that's why it's intense. They either hate you or love you. Identity disturbance, persistent, unstable self-image and sense of self. Yes, again, there's something that happened in which they did not develop an identity. Again, that's part of early childhood development, is developing like a concept of like who you are. They don't necessarily have that. Impulsivity in at least 2 areas that are self-damaging. Doesn't include suicidality or suicide or attempts. Self-image. Spending, sex, substance abuse, reckless driving, and binge eating. Those are some examples. 5, and there's where the suicidal things here, and this is kind of common, unfortunately. Recurrent suicidal behavior, gestures or threats, or self-mutilating behavior, suicide attempts, suicide threats, cutting, things like that. Affective instability due to a marked reactivity of mood. Again, up and down, like that. Episodic dysphoria, irritability, anxiety, and again, it doesn't last a long time, like mania and depression due to bipolar disorder. It can just flip on a dime. Emptiness. Again, that emptiness is kind of going to be due to, again, like the sense of self isn't there. If you don't know who you are, what you stand for, what you value, what's inside? Not a lot. Again, here's the splitting part. Inappropriate, intense anger or difficulty controlling anger. Tempers, constant anger, maybe physical fights. And what you might see are there's these rages. I have seen these. And there's these rages people can go into, and it's almost like they black out, and it's uncontrolled. It doesn't mean they're going to get physical, but it can be that rageful. And then, I mean, they'll do the raging, and then like 5 minutes later, they'll be fine. They'll give you a hug. It's trippy. Also, stress-related paranoid ideation or dissociative symptoms. Again, that's the response to stress commonly as a result of that trauma. And so disassociation is not out of the realm of possibility. I'm going to give you some prevalence rates here. Prevalence rates in, let's see here, right around 1.4%. So again, it's fairly low. It's fairly low. But in the United States, okay, here's another study that showed 2.7%. If somebody's in a primary care setting, again, we're talking about like an inpatient psychiatric facility, right around 6%. In outpatient mental health clinics, it's about 10%. Oh, wait, primary care settings. My bad. I believe that's a primary care setting is a hospital, not necessarily for psychological issues. 10% among individuals in outpatient mental health clinics, like they go in and out for therapy. And then psychiatric inpatients, it's 20%. 1 out of 5 that are psychiatric inpatients, 20%, 1 out of 5. Again, it's thought of as an adult onset disorder, like again, late adolescence, early adulthood, but we have seen it in kids as young as 12 to 13 that meet full criteria. Here's the thing is that, okay, if there is treatment to a certain degree, again, it's really hard to treat. There has to be a certain amount of self-awareness. The disorder can just like lessen. The intensity of it can lessen. Obviously, it's not going away. This is their personality, but the intensity of these symptoms and criteria can lessen as time goes on. Much more common among men than women, or among women than men. That's the same thing. With histrionic personality disorder, mostly women. With antisocial personality disorder, mostly men. Narcissistic, I think it's kind of a, wash, if I'm not mistaken. Oh, no, I'm wrong. 75% are men that have narcissistic personality disorder, so not that many women. Okay, I'm probably gonna have to stop here. Do you guys have any questions right now?